Well, angioedema is seen in about 40% of patients who have chronic spontaneous urticaria. So it is a marker of severity and it has a significant burden on patients with this chronic condition, this chronic inflammatory skin condition. So I think that it's one of the things we look at when we think about, how do we characterize our patients in terms of their severity and their control. Of course, there's different types of angioedema. There's some types of angioedema that don't respond to conventional therapies, and that doesn't necessarily mean that they're not associated with classic urticaria, because up to 20% of patients with angioedema might have isolated angioedema without urticaria. And we have to differentiate histaminergic from non-histaminergic angioedema, and some of those non-histaminergic angioedema cases could be due to drugs like ACE inhibitors, but they could also be due to either hereditary or acquired angioedema, which are rare conditions where there is a defect in either the C1 esterase inhibitor produced or there's a complete absence of it due to mutation in a gene called SERPING1. So I think the biggest thing is for people to differentiate the types of angioedema, because angioedema is not necessarily straightforward. And the fact that they don't necessarily respond to antihistamines is not enough to say, oh, they have hereditary or they have HAE normal complement, because there's a form of angioedema where people have normal complement levels, C1 esterase inhibitor levels, but they swell and they don't respond to antihistamines, and they're being given this name HAE normal complement, and that is sort of a license to prescribe HAE drugs in these patients, which have, in some individuals, effect. They do work in some patients and others not so well, but and they're also very expensive. So there's some steps in between going from unresponsiveness to antihistamines to that diagnosis. And so I think that's really the biggest thing that's confronting us, is to get clinicians to understand the spectrum of angioedema and to make sure that they aren't skipping steps and going from inexpensive antihistamines to extremely expensive drugs that are targeted towards hereditary angioedema. Well, I think that there's a lot been done in terms of diagnosis, in terms of trying to understand endpoints. We now have patient-reported outcome measures for chronic urticaria control test, the urticaria activity score, and we also have the angioedema activity score, which is a validated score. So we can really look at a patient's endpoints, their response to treatment. We don't really have any good biomarkers yet for urticaria or angioedema, at least in terms of diagnosis. We have certain biomarkers that would predict response to antihistamines, good response or poor response, or to these other drugs like omalizumab, which is the only biologic that's currently available for the treatment of chronic urticaria and works in about 45% of patients. But there's many who don't respond, and that's why we need novel therapies. So there's a host of novel therapies that are being developed for chronic spontaneous urticaria with or without angioedema, including the Bruton tyrosine kinase inhibitors. There's like at least 2 or 3 now that are in late stage development that will probably get approval in the next 6 months. And there's also c-KIT inhibitors that are wild type c-KIT inhibitors that are being looked at. We've also looked at, of course, dupilumab, which is IL-4 alpha common chain anti-inflammatory, has many approvals, has completed its studies, and will probably likely get an approval for the treatment of urticaria. Although in that situation, the study showed that it wasn't any more effective than omalizumab. So we'll see how that plays out when we use that clinically. There is, of course, other therapies that have been tried, like Siglec receptor blockers, and unfortunately, those studies met with futility. There's other drugs that have been tried to be repurposed for the use of urticaria, and they haven't really done very well either. So we have some newer therapies that are not as far along. These MRGRP2 receptors, MRGPRX2 receptors, and these are a different receptor on mast cells that can be targeted by and activated by a number of different stimuli. So by blocking these receptors, the idea is that we can prevent hives. And there's at least 2 or 3 companies that are in development, some at later stages, some at earlier stage, at least completing phase 2 studies. So that's exciting. We're learning more about mast cell biology and activation, which is really important in terms of drug development. But we'll see how everything plays out in terms of, looking at these more difficult to treat patients with chronic urticaria and how these drugs work. But I think that we're going to see a significant benefit for patients who don't respond well to antihistamines or omalizumab in responding to some of these other alternative mechanistically driven therapies.